and welcome to this very special webinar where we are celebrating International Women's Day, and we are focusing on one particular aspect, which is heart disease amongst women. In particular, today we'll be discussing aortic and pulmonary valve stenosis and how TAVR is changing the landscape of heart valve treatment. Now, those are a lot of terms that you and I are unfamiliar with. I'm your host, Paramita Chatterjee, and we are joined by a power-packed panel today to understand the incidence of heart disease, the types of heart disease, particularly where heart valves are involved, and how women basically are perhaps not paying enough attention to their hearts, because we have seen, unfortunately, in the past few weeks and months, a lot of notable, in fact, women film stars. I mean, Kavita Chaudhary is one of them, for those of you who have watched Udan, who have suffered from sudden cardiac arrest or have lost their lives to heart disease. Just to give you a sense of what we're talking about on this Women's Day, heart disease is actually responsible for approximately 25% of all deaths. And in women, in particular in India, we find that the prevalence of coronary artery disease in Indian women ranges from 3 to 13% and has increased by almost 300% in the last 2 decades. And in fact, the prevalence of heart failure has more than doubled. The mean age of a heart attack for Indian women now stands at 59 years. And what's alarming here is that women in India are suffering heart attacks at an earlier age than the global average. So on this Women's Day, it is indeed the right platform for all of us to look at our heart health closely and to understand from the very accomplished cardiologists who are joining us from across the country to discuss the same, and of course the latest advancements that are taking place. The special session is brought to you by Times of India and Merrill, and let me introduce you to the panelists who are joining us today. On the session, we have Dr. Deepa S. Kumar. Dr. Kumar is Additional Professor, Division of Pediatric Cardiology at SCTIMST Trivandrum. Welcome, Dr. Deepa. Thank you so much for joining us today.
Thank you. Thank you.
And joining us on the show as well, we've got Dr. M.S. Meenakshi, Senior Interventional Cardiologist at MIOT Hospital, Chennai. We have Dr. Rashi Khare, who is Senior Consultant and Interventional Cardiologist, as well as a heart failure specialist, who are joining us. Thank you, Dr. Khare, for joining us. Which part of the country are you joining us from today?
I'm from Delhi, Fortis Hospital, Delhi.
All right. So, and we have next, a little closer to Delhi, we have from Dehradun, Dr. Preeti Sharma, who's Director, Cardiac Sciences at Max Super Speciality. Thank you, Dr. Preeti, for joining us. Last but not the least, there's Dr. Navneeta Sasikumar, who is Associate Professor, Department of Pediatric Cardiology. She's also in charge of Adult Congenital Heart Disease Service at the Amrita Institute of Medical Sciences in Kochi, Kerala. So as I said, it's a diverse cross-section of cardiologists, women cardiologists, because they can really understand not just why women don't come to their doctors at an earlier stage when they feel those early symptoms of heart disease, but particularly the focus on heart valve disease and the kind of advancements that have taken place. Because unfortunately, the perception is that, heart disease primarily happens to men, but that is indeed not the case. In fact, that's the question that I want to start this discussion with. And let me go across to Dr. Preeti Sharma. Dr. Sharma, when we talk about the incidence of heart disease, and particularly on this Women's Day, how alarming is the situation in India in particular? And when it comes to valvular heart disease, tell us a little bit about it. And of course, what's the proportion of women who have a tendency to suffer from it?
So let me tell you that the heart diseases, which they remain a leading cause of concern worldwide, and because this leads to mortality as well as morbidity in men as well as in women. And now the notion or perception that heart disease or heart attack only is going to affect men or a women after menopause is not true. And now women in early age, they also suffer from heart disease, and the incidence is increasing day by day because the risk factors like diabetes, high blood pressure, obesity, And smoking, increased smoking among women and increased alcohol consumption, these lifestyle also put them, and increasing stress. This all puts them on high risk of having heart disease at early ages also. And because being a female, in most of the studies earlier, they have been neglected. We don't have female specific studies telling about their symptoms, telling about their treatment. So they have been neglected so far. But now is the time that we should have this concept into the mind while we are doing these studies. And now we know that we have to take care of these risk factors in men as well as in women equally, so that we can prevent these heart diseases in women also. And regarding valvular heart diseases, let me tell you, in our heart has 4 valves. And when there is narrowing or leakage in this valve, we call this valvular heart disease. And this can be congenital. You can, while at birth, you can have some diseases related to valves. In younger ages also, you can have rheumatic heart disease. There's an infection which can affect your heart valves and lead to rheumatic heart disease. And specifically in elderly population, we can have calcific valve diseases, which mostly affects aortic valve. So these are the valve diseases. And if we talk of stenosis, stenosis is when your valves is having 3 leaflets which open and close with every jet of blood. So if your valve is narrowed or the leaflets are fused, the blood will not go properly through this valve. So this is stenosis. And if these valve leaflets are not coapting properly, the blood can leak back. So this is valve regurgitation. So this is how you put valvular heart disease.
Okay, those statistics are indeed alarming, and thank you for explaining what exactly valvular stenosis and valvular regurgitation is. But let's understand a little bit about something that we are discussing in particular, and that's aortic valve stenosis. Dr. Meenakshi, if you can just explain to us what is aortic valve stenosis and what are typically the causes, particularly when we talk about women.
So when we talk about aortic valve stenosis, there is, as doctor has already explained, like there is a multiple causes for aortic valve stenosis. There are specific causes which we see in old age is like a degenerative valvular stenosis. So as we get older, the valve gets degenerated. It goes a lot of wear and tear, and it undergoes a lot of calcification. And because of that, it goes for a lot of calcium sitting it and then not allowing the blood to go out of the left ventricle. So aortic valve is the main valve, which is the valve which will be like it's a gateway from the left ventricle, from where the blood is like crossing the valve and then going to the whole body, and it supplies the whole body. So that is a stenosis that occurs due to degenerative calcific stenosis that occurs in older age. And as already doctor has told, in younger age patients, we have multiple other reasons like rheumatic heart disease or bicuspid aortic valve stenosis, and everything can happen. And even bicuspid aortic valve, which is like a congenital abnormality, but these patients will go for a early wear and tear, and they present a little bit earlier than the usual degenerative calcific stenosis.
Okay, so essentially what Dr. Meenakshi is saying, and Dr. Navneeta, I'd like you to take this forward, because it appears that a lot of aortic valve stenosis, and correct me if I'm wrong, it appears when we age. And as we age, the valve undergoes wear and tear and there are calcium deposits. However, there are other factors as well. But if as a woman, I feel that, I'm getting those early symptoms and the body usually gives us those early warning signs, what would they be? And how prevalent is aortic valve stenosis, particularly amongst women?
So as we just heard from Dr. Meenakshi, there are multiple reasons why the valves in the heart can get damaged, particularly when we look at the aortic valve. One of the commonest reasons for damage is the degenerative change that happens with age. And in other situations like a congenital or a rheumatic aortic stenosis, that happens much earlier in life. In fact, even a newly born baby can present with a severe aortic stenosis from a congenital or by birth defect of the heart. Now, when we look at symptoms, it is very important to understand that during the first few years after the development of the narrowing, the patients may not have symptoms. So the initial few months or years, actually, the patient will not experience any difficulty. But as time goes, the narrowing progresses, and then they slowly start getting symptoms. And the common symptoms that an aortic stenosis can present with include tightness of the chest while walking or climbing stairs, shortness of breath, fainting, tiredness. So these are the usual symptoms by which they can present. And onset of symptoms is a warning that the disease has progressed to a severe stage. And once these symptoms set in, it can rapidly progress to heart failure, and the patient may actually even get swollen feet, maybe even breathless while sitting or even sleeping in the later stages of this disease. So it is important that we identify the disease in the earlier stages before it goes to the stage of heart failure and treat it at an appropriate time. Coming to the incidence, which was the second part of the question. So as we know that the degenerative disease is related to age, the older the population, we will get higher numbers of these patients. And in certain studies, it has been shown that around 4% of people in the 70 to 79-year age group has severe aortic stenosis. And when we take even older patients, the number jumps up to even 9.8%. If we look at like how many new cases are detected, approximately 5 cases per 1,000 population per year is the average detection rate when we consider a population with average age of around 60 years. And
Right.
as we know that in the last few years, due to progress in medical fields, the life expectancy of our population is also improving, and hence we will be seeing more and more number of patients with this calcific degenerative type of aortic valve stenosis.
Right. So we've learned something new, that essentially, is as you age, and I think 60 years onwards, or perhaps even earlier, that's barring the special exceptional circumstances, it's important to perhaps, and Dr. Khare, I'm coming to you next, to get those regular checkups, because what Dr. Navneeta was telling us, that in the early stages of aortic valve stenosis, these can actually go without symptoms, as in I may not be aware unless I'm going for regular testing, getting my heart health checked up. So, just tell us a little bit about the importance of, getting those regular tests. What would they be? And if I do have aortic valve stenosis, what are the treatment options?
Yeah, so as it is also already been told that aortic stenosis can occur in any age group. It can be congenital from the newborn baby to elderlies. Now, aortic stenosis is important when it is severe, when it falls in the severe category. If it is mild to moderate, it is not life-threatening, and it just needs some medical management or nothing. When it is mild AS, mild aortic stenosis, we don't need to give anything, or maybe some drugs that can take out the increased urine output and all. But for mild aortic stenosis or moderate, that means the intermediate category, regular checkups are very, very important. When the patient comes in the moderate category, the echocardiogram should be repeated every 3 to 6 months. Because once the patient lands up into severe AS, the risk of sudden death emerges. It has been said that if a patient of having severe aortic stenosis is having breathlessness, then the risk of sudden death is most important in the coming 5 years. Most commonly, that patient, if left untreated, not treated, will have death in the coming 5 years. And if the patient has had a syncope means loss of consciousness, transient loss of consciousness, that patient has a risk of sudden loss of consciousness followed by cardiac arrest within the first 2 years. So once the symptoms emerge after having severe aortic stenosis, it is very, very important.
Right.
Severe AS, for the time being, can be managed with certain drugs that can decrease the workload on the heart, that can increase, because aortic heart is a pump, it is a motor. It just pumps blood outside to the whole body. And the aortic valve is the gatekeeper at the heart. It just protects the heart from regurgitating all the blood outside. So if there is a high blood pressure, then also moderate aortic stenosis can also lead to severe effects. So initially, certain drugs can help, but later on, the patient needs surgical intervention or a TAVR. Surgical intervention is basically open heart surgery. We open the breastbone. The cardiac surgeons do it. We don't do it. So the breastbone is opened, the patient is put on ventilator, then the heart needs a heart-lung machine. We have to, stand still the heart, and then the valve is totally replaced. It is cut de novo from that area, and a new valve is placed. So the new valve that is placed, it can be a mechanical valve or it can be a tissue valve.
Before we go into the mechanical and the kinds of valves, and we'll come to that later. I mean, I think the heart lung, or rather the bypass, heart bypass, which is perhaps something that most of us refer to, which is the open heart surgery. I mean, that is something that really evokes a lot of apprehension in many patients, especially women. And today we are talking about TAVR. I mean, clearly, technology has moved on, medical science has moved on. So one is the open heart surgery option. Tell us a little bit about the newer options which have come up, if surgery is indeed required for the extreme cases of the disease.
The first option till these years has been surgical aortic valve replacement. We have two different valves for that, but the newer modalities that have come is TAVR. That does not require that, it is not so invasive. We don't need to open the heart, the chest bone, the breastbone, then we don't need to stand still the heart. We can just, it's just like an angioplasty. We just put a needle in the groin area, and through the vessels, we go to the heart, and we just put another valve inside that valve that is already stenosed. It is a tissue valve, and it basically, it is just like a stent. The patient does not need very high blood thinners that need routine monitoring throughout life. He can take a double antiplatelets that are taken in stenting patients, and it is good to go. So this is the latest advancement that has come. The patient can be mobile 6 to 8 hours after the procedure, or even at least morning. He or she can walk the next day and can be discharged in a day or two. He or she can resume their daily activities in, I think, in 4 to 5 days, and they can even go to work in a week. They can start their walking and all.
So I think from a layperson's perspective, and for those of us who are mums, I mean, it's almost like, a C-section kind of in terms of duration of time in the hospital. So you're saying just 4 to 5 days because,
C-section.
Yes, of course, it is. Oh, okay. It's right. So, because since we are talking about women here on International Women's Day. Now, Dr. Deepa, the topic of conversation today, we've spoken about aortic valve stenosis, but there's also something known as pulmonary valve disease. I mean, what's the difference? Is it pretty much the same? Explain to us what is pulmonary valve disease and what are the factors that lead to it?
Yeah, so it is very, very different from aortic valve disease. As the previous speakers have mentioned, aortic valve disease is predominantly a disease of old age. As you age, the valve gets degenerated. So, but in pulmonary valve disease, it is mostly congenital. That is, you're born with some abnormalities of the pulmonary valve. So, mostly. So, it can have degeneration as well, but it is quite rare compared to aortic valve. So, commonest cause of pulmonary stenosis is there is some anatomical abnormality. There is some abnormality per se with the valve that prevents it from opening fully. So that is one problem that can happen with the pulmonary valve. But much more common than that, what we are facing now is pulmonary regurgitation. That means pulmonary leak. So valve function is to allow the blood to go forward only. It should not allow the blood to come back. So when that mechanism is damaged, you end up with pulmonary regurgitation, which also leads to a lot of problems. In fact, sometimes even more problems than if you have a pulmonary stenosis. So a pulmonary regurgitation usually is man-made, like it is something that the doctor inadvertently gives to a patient who has had a surgery for a heart disease, which is a baby will be born blue. It will be a blue baby called tetralogy and the surgeon operates on it, and inadvertently, when the valve, there is a valve stenosis in tetralogy and when the surgeon tries to correct it, we almost always end up with a pulmonary valve leak. So
Okay.
we are designed to give new pulmonary valves to these patients, maybe 20 years down the lane, 25 years down the lane. We are also committing them to several changes of pulmonary valve during their lifetime. So we are actually facing more need for pulmonary valve replacement in pulmonary regurgitation than for pulmonary stenosis. So these are the pulmonary valve diseases. Yeah.
Okay, that's that's something that you've explained to us. I think a takeaway, and Dr. Navneeta, I'm going to come to you here because we have a lot of laypersons, viewers who perhaps are not aware of these technical terms. And the thing is that one wants to know the difference between pulmonary valve disease from what Dr. Deepa is saying is you could be born with it, or it could be a procedure during a procedure performed that inadvertently leads to this. Whereas aortic valve disease, is usually happens, and usually I'm saying in majority of cases is due to advancing age. Would you be able to tell us a few more differences between the two?
Yeah, so essentially, it's a sea of difference between the two, because as we mentioned already, the reasons why the disease comes in is grossly different between the pulmonary valve and the aortic valve. As you mentioned, age is one of the commonest reasons, or degeneration is on the aortic side. It is by birth or congenital on the pulmonary side. So the pulmonary valve connects the pumping chamber on the right side to the blood tube that carries blood to the lungs. So, so what happens when there is a stenosis on the pulmonary side versus that on the aortic side? When it comes to treatment options, the degenerative aortic stenosis, there is little role for something, a very simple type of procedure that we call a balloon valvuloplasty. So in the elderly with aortic stenosis, the balloon actually does not give a great result, and hence we need to go ahead with a replacement of the valve. On the other hand, when we look at the pulmonary side, in congenital pulmonary stenosis, almost always, well, there are exceptions, but almost always, when the problem is narrowing, the treatment, we can get away with a balloon angioplasty, which is a much simpler procedure compared to a valve replacement. That is one of the major differences. But on the pulmonary side also, when the primary problem is a leak, so when it comes to leak, the leak is tolerated for a much longer time than a narrowing. But ultimately, that also leads to damage to the right side of the heart, and that also needs treatment. And leak on the right side is primarily managed by valve replacement. So these are the major differences between the right side and the left side of the heart valves. That is a pulmonary valve on the right and the aortic valve on the left side. And it was already mentioned that the leak on the pulmonary side actually is a part and parcel of the treatment for some of the very common congenital heart defects. And it is well tolerated for a large number of years, and that is why it is accepted even as part of the treatment. And later, 5, 10, 15, 20 years down the lane, then this starts creating problems. And hence, it is very important that every patient who as a child has undergone an open heart surgery needs regular checkups with a specialist, so that these things can be tracked and the appropriate decisions taken at the right time.
I think that's a very important information that you've given to our viewers, that if anybody has had open heart surgery as a child, then immediately you should be checked regularly for this. But having said that, we were just talking about TAVR. Can TAVR be used for both cases of stenosis?
Yeah, so that is the beauty of it. So far, when it came to the treatment scenario, even the pulmonary valve was only being surgically replaced. And we should remember that these patients some of them have actually undergone 2 or 3 open heart surgeries even before they reach the stage that where they need a pulmonary valve. So these surgeries become increasingly difficult, longer, and for both the patients as well as the treating team, it takes whole days to get one redo pulmonary valve done sometimes, because of the fact that they've already undergone multiple surgeries. And now we have this technology whereby the valve can be implanted in a keyhole procedure, which includes just a nick in the leg vein, and the valve can go in very similar to the balloon technique that I just mentioned. But the difference is that there is a valve on top of the balloon, and we can use that valve technology in replacement technology, which is the TAVR technology, on the right side as well. We call it as a percutaneous pulmonary valve replacement.
Okay, great. So the good news is we have this new procedure that can be used to treat both kinds of diseases. Let's take a quick break at this point in time. We are, of course, being joined by eminent cardiologists, women cardiologists on International Women's Day to discuss the various kinds of heart disease, particularly heart valve diseases, and the latest advancements in treatment. Stay with us. Welcome back to our very special webinar on International Women's Day, where we are putting the focus on heart disease in women and particularly heart valve disease. And there have been some dramatic advancements, as we heard from our doctors earlier, in terms of how heart valve disease, particularly when it comes to women, is treated. So we needn't always go down the open heart surgery route, which is perhaps an apprehension that keeps a lot of patients away from coming to their doctor's office. Let me go across to Dr. Preeti Sharma, who is there with us. Dr. Sharma, tell us about how, TAVR, which is the transcatheter valve replacement, and we were learning about that, how it basically means just 4 to 5 days of hospital stay. And, it's not invasive, such as an open heart surgery, but clearly, there are many more benefits. How is TAVR a better option for both cases of valve stenosis than open heart surgery?
So, as we have already listened to our colleagues, that the surgical valve replacement needs your chest to be opened, you have to be put on heart lung machine to get access to this aortic valve, and then they can really replace this valve and put a new valve. So this is in patients like elderly populations, and with patients who have risk factors, like who have lung diseases and all. So this is a high risk procedure for these patients. And TAVR, on the contrary, we are taking this catheter mount valve through the groin artery, which is a simple procedure, and it is done in around 1 hour's time, because everything is pre-planned. And you can actually mobilize your patient with the same evening or the next day. And I would tell you that the discharge is a little faster. Maybe the second or third day you can send your patient home. So the TAVR is better because your patient don't need to have their chest cracked open, number one. This is faster recovery. And these patients who are high-risk patients for surgery, earlier they were denied any treatment. And most of the patient used to die because of a lack of any treatment. Now with the TAVR, this is a simple procedure. We can offer these patients at least this therapy to improve their symptoms as well as their longevity. So this is a remarkable change in management of TAVR, in management of surgical aortic valve stenosis. With TAVR, we can offer this therapy to many elderly patients and high-risk patients who are not considered good for surgery. Because this actually maybe this is good for some patient, but actually carries a lot of risk for high-risk patients.
Indeed, and I think you've made that point brilliantly. So open heart surgery is not actually always the option. Now we have TAVR. And Dr. Meenakshi, if you could just take us through step by step, because as Dr. Preeti said, it just means 2 to 3 days of hospitalization, but the chest won't be cracked open, which is a big fear with open heart surgery. So step by step, when one chooses to undergo a TAVR procedure, what does it entail?
Like when we have a patient with severe aortic stenosis, and we always choose a TAVR or a SAVR based on the multiple risk factors. So there is a lot of score systems which says that this patient is very high risk for a surgical AVR. So those patients we just categorize as very high risk, or like a low risk or intermediate risk. So in previous days we were using TAVR for high risk patients. Now the indications are coming to intermediate and low risk patients also, because of the ease of the procedure, the early recovery, and patient also feels very comfortable doing the procedure. So when it comes to high-risk patients, the main risk factors, like as Dr. Preeti told, it is about the anesthesia, whether the patient will tolerate the anesthesia, come out of ventilator after a prolonged surgery, recover from the surgical things like opening the chest wall, and it takes 6 to 7 days to come out of the hospital, and the patient to recover and come to routine activities. It takes almost 2 to 3 months. Okay, it is for a normal patient, like a normal well-preserved patients. But our group of population who have TAVR, or like a 70 plus or 80 plus patients who are not very fragile, who are like a very not well preserved patients with multiple comorbidities. For these patients, TAVR is really a very boon where it restores the quality of life and restores their routine activities as early as possible. Maybe within 3 to 4 days, they'll be back to their routine activities. That is the advantage of having a TAVR. So coming to the procedure as such. So we just make a small nick in the left or right groin arteries. So before going for a TAVR, we do all the planning on a CT iotogram. So the CT iotogram is called a gated CT iotogram, where we just analyze the anatomy of the aortic valve, how much calcification it contains, what is the size, and how's the arch, is there any risk of stroke, how is the peripheral arteries, is a patient can go through the groin, or we need to have alternate routes like going through a subclavian artery or a carotid artery. So all the planning is done with a one CT iotogram, which says like what kind of valve is needed, what is the size of the valve, and what is the route we have to go. And
so there is a lot of pre-planning which is involved, step by step about it.
Step by step.
Now, having said that, Dr. Navneeta, what do you think is the level of awareness? I mean, how many of your patients, for instance, are aware that there is this new kind of procedure?
So yeah, it is one of the newer additions to the armamentarium that we have for treating valve disease patients. And hence, I would say that the awareness level is actually low, even among physicians as well as the general public. And for this reason, as Dr. Meenakshi was mentioning, a good number of the higher risk patients for either of the valve replacements, like, when they are high risk for surgery, where there is a chance that, we may lose the patient during surgery, then the surgeon denies treatment. So a lot of such patients can actually get the procedures done during this less invasive, less morbid percutaneous modality. And it is important that we increase awareness about it among the public as well as...
I think the message here is for any patients who have, for instance, have been told, listen, open heart surgery is not an option. Talk to your doctor about this new procedure, which is TAVR. And we've learned so much more about it. But let's come to the valves. And Dr. Meenakshi, I'll take it back to you. What are the kind of valves which are used in this procedure?
So usually it is two kinds of valves we have. One is a balloon expandable valve, another is a self-expanding valve. Okay. So basically the valves are acquired is a bovine valve or a porcine valve. So we acquire it from the cow or pigs, and then it is processed, bioengineered so that it is suitable for human use. And it is mounted on a metal frame. Because the surgeon removes the valve and then he stitches the valve to the native tissues. But here we are going to replace the valve on a native valve. So it has a metal frame on which the valve is attached, and we just the valve is just mounted on a sheath. If it is a self-expanding valve, it just opens like an umbrella and just sits on the right position. Once we place it on the right position, and then it just sits on it like an umbrella. Or if it is a balloon expandable valve, it is mounted on a balloon, and we go inside on the right position, we place it and expand the balloon, and the valve just places on it.
Okay, so you have a balloon, and you have the balloon expandable and the self-expandable kind of valve. Now, Dr. Preeti, let me
I want to add one thing. We need some calcium for the valve to hold on that place. So if there is not any calcium, the valve will not be holded. Okay, so it is a very much prerequisite, so that is the reason we cannot offer this treatment for younger patients who doesn't have calcium in the valves.
Okay, so perhaps that means, we need some tests, Dr. Preeti. I mean, not everyone, that means, is suitable to undergo TAVR. What are those tests?
So whenever clinically we suspect that the patient with the symptoms he has consulted in an OPD, he or she has consulted. So if we are suspecting that patient can have aortic stenosis, the first test we do is 2D echo. So echo Doppler will tell us about whether the patient is having aortic stenosis. And then we do a couple of tests, as Dr. Meenakshi has mentioned, CT aortogram, which is the foremost, this is the important thing in planning the procedure. And along with this, we have to see a couple of things, like if a patient is having diseases in the brain arteries, which can predispose them for stroke, like carotid Doppler, or if they are having some lung diseases, we can conduct EFT on these patients. So these are the basic tests we do, and then we have to check their coronary arteries, the arteries which are supplying blood to their heart muscle. So these are three important steps for planning TAVR in a patient. So this is how we take these patients from OPD to the planning and to performing the procedure.
Okay, so it's a fairly rigorous kind of testing to make sure that the patient is actually eligible, echo 2D, CT angio, and many more tests, depending on what are those perhaps what we call as comorbidities. Now, perhaps a lot of our viewers don't understand comorbidities. And Dr. Deepa, let me come to you here, because we are told many times that India is a land of diabetics. We've got hypertensives, there's obesity, which is on the rise. Are these what we would generally refer to as comorbidities? What does it mean, and how does it impact whether or not a patient is fit for TAVR?
Comorbidities differ when you're planning a aortic valve replacement versus a pulmonary valve replacement. So as we mentioned earlier, aortic valve replacement we do mostly for old age. So as you know, all these lifestyle diseases manifest in old age, and you add on the risk once you have diabetes, hypertension, high cholesterol. You're adding on your risk of undergoing a cardiac surgery when you have all these risk factors. And on top of that, if you have a coronary artery disease, that you have a disease affecting the arteries that supply blood to the heart, so then it compounds the risk factor to very high levels. And if you have long-standing diabetes or hypertension, part of the problems of diabetes and hypertension are that it affects other organs like the kidneys, and it all keeps on incrementally adding to the risk of undergoing a surgery. So we have various scoring systems whereby you can predict the risk a patient is going to have if the patient is going to have surgery with all these pre-existing conditions. So if the score is quite high, then we would suggest doing a percutaneous aortic valve replacement. The scenario is totally different in a pulmonary valve replacement because, as I mentioned, it is done in younger patients. So our patient population where we will be doing a pulmonary valve replacement would be around 20-25 years. So they obviously will not be suffering too much from diabetes or hypertension or coronary artery disease, but they will have other set of problems like, as I mentioned, pulmonary valve disease is usually a congenital disease. So they might be having other associated congenital problems like maybe absent one lung or absent artery to one lung, or they may be having some spine anomalies making them have severe scoliosis.
But as you said, the younger patient profiles, I mean, around 25 or so in their 20s, typically one would not have these comorbidities like a diabetes or a hypertension. At least one would hope so. I'm sure you do so when you look at your patients, that's the case. But and Dr. Rashi Khare, let me come to you here from what Dr. Deepa is saying is, would it be fair to say that, the higher the comorbidities, the greater is the suitability for a procedure like TAVR? And if one does undergo TAVR, what would be the protocol? What would I need to undergo? I mean, it's obviously I won't be wheeled in straight away. I need to undergo certain steps in terms of diet, for instance, and so on and so forth.
So yeah, the statement is correct that more the comorbidities, more the patient is eligible for TAVR. So in our scenario, like the elderly patients who have kidney diseases, renal dysfunctions, lung diseases, even the young population who is having bronchial asthma, severe asthmatic disease, when the patient is put on ventilator, the chances of coming out of the ventilator with ease is less, particularly in the elderly population. Secondly, when the patient is having kidney disease and diabetes affects the peripheral arterial disease, the vessels of the legs. So in all these scenarios, the results of open heart surgery are compromised. In these patients, TAVR is an ideal approach. So TAVR is not decided by a single cardiologist. We have got a heart team. The heart team comprises of a cardiac surgeon as well, who does the open heart surgery for the valve. So it comprises a cardiac surgeon, it comprises an interventional cardiologist, then a radiologist has to be part of the team because the CT angio helps us to make the decision about the valve size, the distance of the coronary artery, the vessels of the heart that supply the blood to the heart, their distance from the valve. All this is important because when we are doing the TAVR is a minimally invasive procedure. We don't have the heart open in front of us.
So this is because it's a minimally invasive procedure, Dr. Khare. It means that basically that's why you were saying that patients can actually come back home within, say, 48 to 72 hours. Is that a fair premise?
Yeah. The patient can walk after around 8 to 10 hours, maybe 12 hours. And he or she can go home after 48 to 72 hours. It depends on the patient. Some may go in 48 hours, otherwise 72 hours, most of the patients go home.
Right, because it's a minimally invasive procedure. Let's take a quick break. We've learned a lot about heart valves, about heart disease, about TAVR, and who is eligible, who isn't. But we have more questions for our team of doctors here today. You're watching our special session on International Women's Day, particularly focusing on heart valve disease in women. Stay with us. Welcome back to our special webinar where we are discussing heart valve disease and how it affects women. And the number of women who are getting impacted by this seems to be growing. A lot of it is a factor of advancing age. But as we've seen, women perhaps don't walk into the doctor's office as quickly as their male counterparts do. Or even if they do, maybe they don't ask the right questions. Now, Dr. Deepa, we've been learning about this new procedure, which is TAVR, which is minimally invasive. Patients with valve disease can actually go home. But having said that, how long will a valve which has been used using TAVR procedure, how long will it actually last?
So that's a very important question because that is the first thing that we counsel when a patient comes asking for percutaneous valve replacement. So the difference between a percutaneous minimally invasive valve replacement compared to a surgical valve replacement is that we are putting in a bioprosthetic valve. That means you're putting in the pericardium of either a bovine pericardium or from a pig. So we cannot use a mechanical valve. Mechanical valve can go on for years and years, in fact, lifelong. But these bioprosthetic valves that are made from tissues of other animals, they have a finite lifespan. So always tell them that, see, the advantage is that you don't have to take blood thinning medication. You're free to, stop blood thinning medication after maybe 2-3 months. But you're left with a valve that can undergo degeneration after an average of some maybe 10 to 15 years. And that depends mostly on your age. So if you're quite old to begin with, for example, if you're more than 75, you obviously you don't need to do a second valve replacement after you put in this because you probably will get 10 to 15 years. And even if that degenerates, you are able to put in another valve inside this valve, if that also minimally invasive. But this problem happens when you are doing a minimally invasive procedure for a pulmonary valve replacement. As I mentioned earlier, we are doing it on young patients. So we have to tell them that, see, once you put it in, we hope that this will last for 10 to 15 years. And as this one degenerates, we may have to put another one or maybe two, three down the lane and for the entire lifespan. So, but each one, we are hoping that we will be able to put minimally invasively valve by valve. So,
it is, I think, only a matter of time. So, but right now, the news is that if you are on the younger side, then perhaps, these valves will last for about 10, 15 years. You'd want them to last longer because you don't want to keep undergoing this procedure. But if you are a senior citizen and older, then perhaps this is the right valve replacement for you, given the fact that they can last up to 10 to 15 years with good management. Now, Dr. Navneeta, I want to ask you, you mentioned the fact that there's not much awareness about TAVR, not just amongst patients, but even amongst doctors. So how many institutions in India would you say in a ballpark number actually perform this surgery, and how many valve replacements actually take place annually?
So I would say that we do not have exact numbers of surgical valve replacements, but a ballpark figure for a year would be around 30 to 50,000 surgical valve replacements happening in India. We should remember that a lot of patients in India are not getting their treatment done for various reasons, which not only includes comorbidities, but will also include financial reasons. And when we look at the capacity to do the procedure, we do have, India is blessed with a large number of tertiary care centers where we have eminent people who have been trained in this procedure. So on the aortic valve side, the TAVR procedure, maybe around like 200 centers have performed so far. But when you look at the pulmonary side, it is a highly specialized subset of patients, as well as a highly specialized procedure with much more intricacies and complexities compared to the aortic valve. As Dr. just mentioned, because they may need multiple procedures in their lifetime. We have to be very careful when we advise this. We should not be advising it earlier also. So the right timing is important, because they may need, so when we advise it at the right time, we can reduce the number of procedures that they need over their lifetime. So this procedure on the pulmonary side may be being done in around 10 centers in the country. That would be an approximate number.
Okay, so aortic valve replacement using TAVR is done far more widely, as you said about, I mean, we don't have an exact figure, about 200 or so, but pulmonary valve replacement using TAVR is done in very few centers, about 10 or so. So Dr. Meenakshi, overall, we just heard the number of between 30 to 50,000 valve replacements being done in India. What's the proportion of, valve replacements being done using TAVR across these categories? Just a number.
Usually, like in the older age, like 70 plus, almost 80 to 90% of the valve replacements is nowadays like TAVR. And we don't have any particular percentage to say among the surgical AVR and TAVR. But overall in India, we do around 2,000 to 2,500 TAVR, transcatheter valve procedures. It includes like already we have done a mitral valve replacement with a bioprosthetic valve or a aortic valve replacement, all the valve therapies together. So we averagely do around 2,000 to 2,500 per year. Across the country.
That's a minuscule proportion if you look at it, because looking at the benefits, especially when it comes to senior citizens, it could be much more. But the fact of the matter is, and Dr. Rashi Khare, let me come to you here, it is an expensive procedure. It is more expensive, would I be correct in saying, than open heart surgery? But patients clearly benefit, especially in terms of the recovery time. So if I'm a patient who's keen on TAVR, perhaps I don't have the financial means to, fund myself, what are the potential solutions to address some of these financial considerations?
Yeah, so that is a problem in the Indian scenario, that we don't have a mandatory health insurance for all the patients. So patients have to pay for their treatment. So TAVR is not a very costly procedure, but yes, definitely it is more costly than the open heart surgery for the valves. So there are the companies are providing loans for the procedures for the patients who are not able to, the proper funds, or some fundraising can be raised. So efforts are being made, although not substantial till now, but definitely loans are being provided by the company so that patients can afford and get the proper treatment.
So would you say, Dr. Khare, that, health insurance, that's again something that many of us don't go in for. We just go in for our life insurance, not for health insurance. Do most health insurance policies cover the cost of this procedure?
70% to 80% of my patients are covered by insurance, and insurance does cover TAVR. So it is not a problem when the patient is insured. The insurance does cover it.
Okay, I think that's a great point. And we're going to take those takeaways at the end of this webinar. But very quickly, Dr. Preeti Sharma, it is a large reason for the cost going up when it comes to TAVR is because a lot of these valves, a lot of the, instruments used were actually getting imported. How have we moved forward in terms of self-reliance and really getting some of these valves and prosthetics being made in India?
So this therapy tower was launched in 2012. And most of our patients could not afford the therapy because these imported valves were costly. And now the good news is that now we are developing these valves indigenously. So we can make these valves in India. And we did some trials and some human studies to compare these valves with the imported valves. And they do very good in our patients, Indian patients. And the good news is that these valves are now approved in European countries also. And even these valves are being implanted worldwide. And
Right.
so this is a big development in field of cardiology, if from Indian perspective. And the patients who could not afford this therapy now, with people with limited resources, we can help these patients with these Indian valves, and we can reach out to the masses. So this is a great news for these patients who are suffering from aortic
Indeed, and
stenosis.
it looks like the price graph should only go down as we become more and more.
It has 40% less cost from the imported valves. So this is good for our Indian patients who are not having any insurance or anything. So it's mostly affordable to a big group of patients. I would put it that way. Yeah, now. Yeah.
Okay, so that's the good news. Even if you haven't gone in for health insurance, the cost is coming down, and you share the number 40% cheaper is what Indian valves are now, and they're actually being used overseas as well. So it's, they're meeting the cutting edge industry standards in order for them to be used in a procedure like TAVR. Now, it is International Women's Day, and despite all the efforts, women continue to ignore their health, especially when it comes to that heart health. And I'm sure that's a point of frustration, doctors, for you, when you see women coming to you in advanced stages of disease. So I would like each one of you to share your, short message on International Women's Day. How can women protect their heart health better? What should be that one thing they should change today? Dr. Deepa, let me start with you.
So I would say more me time, and me time would entail a healthy lifestyle and exercise, which is extremely important. If your routine household work does not qualify for exercise, so routine, regular exercise, a proper diet, and listen to your body when it says it needs help. Please go for help.
Wonderful, Dr. Meenakshi.
So, as Dr. Deepa told, we should, after 40, you should have time for yourself to keep yourself healthy and look fit. And another thing, what I say is, don't ignore your symptoms, even though it is a very minimal symptom, even though you feel it may not be anything. Just go to the doctor and check yourself and confirm that those symptoms are not pathological. That's what I like to say.
Okay, don't ignore your symptoms. Both the doctors are saying that. And especially if those symptoms come, and that's the big M word, right, on Women's Day, menopause. Dr. Navneeta, as women head towards menopause, most women think, hey, I'm protected from heart disease. My husband may be suffering from it, but, I won't, or I have a lower risk. What happens after menopause? What would be the one advice you would give women who have crossed that threshold?
So what I would say, Paramita, is rather than looking at it when we cross or reach the age of menopause, this should happen at the earliest. Like if we start in our 20s, we'll get the maximum benefit. So there is no substitute to a proper diet and regular exercise, and that should start at the earliest, so that we do not have these issues accumulating all through our lives. And by the time we reach menopause, we actually are able to be in a better position than without these. And one more thing that I want to say is stress is a very important factor, and it adds to everything and compounds everything. It puts us in a chronic inflammatory state, which is not good at all. And we should find our own ways of de-stressing. And I would say that having a lot of good friends is a very good strategy. Take your effort to keep connected with your friends, share your troubles, and de-stress yourself. That is very important.
Yes, indeed, because it is indeed only one life. Let's, de-stress, let's, laugh it off. And Dr. Khare, if I may say so, also go to that clinic and get that health checkup. I mean, how many women are doing that?
Yeah. So one point that needs to be added is, please get yourself checked properly. Periodically after 40, get your blood sugars test done, BP done, and a stress echo done once in a year is enough. But after 40, everybody, be it a male, be it a female, needs to have periodical checkups every once in a year. And rest, I think best part is keep stress away. Don't let stress, hang on you. So that is most important.
Indeed. And it all comes to our minds. We need to stop overthinking. I think as women, we really overthink all the time, or we just take the world's worries on us. Dr. Preeti Sharma, final advice from you.
So I would add that everybody has spoken about many things which you should take care. So my only message to all females, as we are performing trying to perform best in every front. So just take care of your body also in those spirits, and cut down on stress and have a good sleep at night, which is very important, which we actually all of us forgot to mention. A good sleep is the key, and 6 to 8 hours of sleep I think we all should have at night, and just don't be consumed in all this career making, in all these stress of moving forward. We have to actually see some signs and symptoms and just follow and listen to your body, and then act accordingly. So this is my message to most of the people who are now joined with us. Yeah.
I think I'm getting some great takeaways. I'm going to make myself the most important person, stop thinking about everybody else. And as you said, stress, it's all in the mind, but we need our diet and exercise to help ourselves. And of course, go to that doctor's office, go in for that health insurance. Stop ignoring your symptoms. I think we've got some wonderful advice from such a wonderful team of women cardiologists. It always gives me great pleasure to connect with women, and you're all doing such a wonderful job of taking care of your patients. Thank you for joining us. Thank you for sharing your insights. And thank you to our viewers. Remember, after listening to this webinar, take those important steps to protect yourself from heart disease and don't ignore those symptoms. Thank you so much for joining us.